I don't have words, to be honest, to present the next speakers. His name presents himself alone. I would like to invite Dr. Manuel Rigo. What to say? Welcome, Dr. Rigo, to this activity you have created, and you invite all of us to be here with you. I repeat, I don't have words, but it's true that I need to say something. We are in front of a very good, professional, ethical, and always respecting the patient and the family. Never has put his own interest before the patient. And look at, after, I don't know how many years, if we can say how many years or not, after many years, he has the same spirit, he has the same soul, he has the same energy to be with all of us. Dr. Rigo, thank you very much, and we will be ready to learn, as always, from you. Thank you.
I have no particular presentation here today, this morning, because, well, I have few slides that I will be using, but at the end of the day, if this event that Gary has organized so well, I congratulate you, Gary, for organizing this first event, which is called Rigo Invites, meaning I cannot really invite myself. So I told him, Gary, you have to do something. I cannot make a classical presentation. So I'm going to do just a closing remarks about what I have listened, some reflections. And first of all, yeah, this is for later, yeah. First of all, what is behind about this Rigo concept is a name, you know, people who know me knows about how allergic I am about using my own name for anything, because I invented nothing indeed, even after this sentence that we are using so much, looking after the patient, not after just the curvature, is nothing new indeed. Huh? Okay, so the reason for the name is that I am aware about the influence that I have had into the world of physiotherapy, of scoliosis, also in the world of bracing of the orthotics. So I understand using this name, but in the world of medicine, this is nothing new. It's nothing invented. It's for all the history of medicine, it has been that way. So you might think that maybe some doctors are not following this idea, but most of the doctors in the world who has been attending a faculty of medicine in any university are following this same concept. I remember I was studying in the Universitat Autònoma de Barcelona, and my professor in medicine, internal medicine, Dr. Savall, the first sentence going into the room, the first lesson, the first sentence was, we are not treating a disease, we are treating patients. I mean, and I am sure that this sentence is given by all the teachers, all the professors at any university. So this is medicine, is looking at the patient, not at the disease. And this is also related about adapting the treatment we have to the patient, not the patient to the treatment. So this is behind medicine all life, so this is nothing new. We have invented nothing about that. So we have to take care about how we use now this, okay? So I want to thank very much Gary for organizing this. I want to invite you also for coming here on a Saturday. I mean, you could be with your family on Saturday. Also, all the people attending the meeting online. And of course, I want to thank very much the two first invited speakers that we had this morning here, Dr. Sabrina Doncelli and Dr. Judith Sanchez Raya, because for me, they are two specialists in physical medicine and rehabilitation that show people that the interdisciplinary team approach is possible, is feasible, and is both in the public medicine as well as in the private medicine, okay? So for me are two persons that I respect very much. I listen to them very much. I learn a lot from them because they are very, really good in research. I am more a clinician, not so educated in research. I had to do it by myself. And so I respect them and I learn very much from them. So what I wanted to say here is that the tools that we are still using, meaning observation, specific physiotherapy, bracing, even surgery, is nothing new. These are all very old tools that we have been using since 18th, 19th, 20th century. Okay, and if we pay attention to the sentence from Einstein that Gary showed in the first talk, if we try to solve a problem with the same tools that failed, probably we're going to continue failing and maybe even creating more problems. We should have a look to this. We are using the same tools we have been using for at least 2 centuries. Okay, so what has really changed is the knowledge about what we are treating now, but the tools are the same. And we have really to pay attention in the way we use the tools, in the way we develop these tools that we have in order to make a more efficient treatment and in order especially to make a safer treatment. It's very important to avoid iatrogeny. We are more conscious about iatrogeny by knowing better the trouble we are treating here, people developing a scoliosis. But we really need to prevent, to take care about this, because any intervention in health science, call it physiotherapy, call it bracing, call it surgery, every intervention can have some benefits, but also for sure produce iatrogeny, can have some adverse effects. And we have to really look at this, where the side effects, the adverse effects are, and which kind of iatrogeny we are producing without our tools, with the tools we are using. Be aware also, physiotherapists, that physiotherapy can also produce adverse effects, not only bracing, not only surgery, okay? So, following with this, we need to continue learning about what scoliosis is. We need a lot of research to understand what is that and how we can add new tools, because at the moment we have no new tools. New tools could be in the field of pharmacology, to have, for example, some pharmacological treatment for scoliosis, and other ideas like this. So this is research. While we don't know really individually what is going to happen with somebody developing scoliosis, we are now with our hands really that way, and we have again still the same tools that we have been using all life, okay? So we need to learn more. I have the feeling, yesterday I was in Valencia for a meeting on scoliosis organized by the Spanish group of the spine, the hair, and organized by the doctors Teresa Bas and David Farrington and Oscar Riquelme. The three are surgeons, but Teresa Bas was presenting a research about predicting the scoliosis evolution and progression from biomarkers. She has been doing research on epigenetics. Epigenetics factors nowadays is one of the main fields of research, but we will have for sure in not a very long time some biomarkers and also some way to predict the evolution of scoliosis from the initial analysis of the three-dimensional geometry of the spine. So we will know someday about which is going to be the individual prognosis, which is going to be the individual evolution of the scoliosis. This will allow us to use the tools we have in a better way and also we will know about the type of response we can have. So who is going to respond to this, or to that tool. This is going to be a very important moment. Looking back to when I finished medicine, and I was working in the field of allergy and clinical immunology. There was a pathology, again, a disease, asthma, okay? We were all the time looking not just at the pathology, but at the patients at that time. And it was the time when the general asthma was subdivided in many different types. Intrinsic asthma, extrinsic asthma, extrinsic due to this allergen, to this other, intrinsic related with the response to aspirin, etc. So I have the feeling that we are now in this step in the scoliosis world about being able to subdivide the different types of scoliosis that we have into this big box that we call idiopathic scoliosis, okay? So still we have asthma, okay? And we will have scoliosis. Don't worry about that. We will have scoliosis in the future. But we will know better how to use every tool at every moment. So this is very important, the talk that Sabrina Donzelli has been doing here. It's about really deciding together with the patient and the family which tool use in which proper time to obtain the best benefit and preventing, again, the side effects or the iatrogenic, okay? So for that, again, it's very important, the interdisciplinary team approach, because as more information from research we will have, the way information is now in the world and how people, families, patients can, let's say, afford this information by themselves, this is also something that we have to say is dangerous in terms of promoting the self-prescription. I mean, evidence-based medicine is not only paying attention to the external evidence, is a nice combination of external evidence, experience, and patient preferences. But patient preferences, we have to listen to patient's preference. We have to understand what patients are looking for and for what they do things. And then we have to give them quite or very neutral information about what the evidence says. We have to be very honest about that. And then we have to give them some advice from our experience. This is team approach. Is not for the families looking at the information and the tools they have. The bar is open, you know. I go to this, to this, to that. I go to this doctor, I go to this physiotherapist, I go to this orthotist because I want this, I want this, I want this from the market. This is not good. The interdisciplinary team approach is something different. Let's have the first slide, please. So looking at this, this interdisciplinary team approach, again, is nothing new. This is something that has been developed in the world of medicine for a long time. And if you look at this paper published by the group, by the ISICO group, where Sabrina Donzelli is working, you see that this is the evidence-based personalized approach based on the interdisciplinary model, okay? That means that we are not doing in the world of scoliosis, so we shouldn't just do things by protocol. Typical question, which is the cup angle you recommend surgery? Which is the cup angle you recommend a brace? It's not about which is the cup angle, it's about the patient and many other things aside of the cup angle. So this is the evidence-based personalized approach. And you see here a very simple model of the interdisciplinary approach with one single medical doctor, one single physiotherapist, one single orthotist or CPO. I don't care about if you turn this and who is in the top. This is not about that. This is intercommunication with the family and the patient in the middle. If this model is not easy to manage, just the communication between three people sometimes is difficult, especially in border or patients being in a gray zone for any decision. If this is complex, imagine what can happen if we have this, sorry, I have to go forward. If we have this, okay, we have more than one doctor, more than one physiotherapist, more than one orthotist working with the patient in the middle. We have very many lines of communication that can create problems. Okay, so simplest is the model, probably the best for feasibility working. In this model, for example, what is typical when you have a difficult patient? Okay, you have, for example, a patient who is not responding well to bracing. Then the doctor is asking the orthotist, you have to do something. This brace is not working well. Okay, and the orthotist says, but I can do nothing else. I am doing all what I know to do with this brace. And then you have the doctor telling, see whether if you can push more to get more correction. And then you have the physiotherapist looking at the brace, looking at the doctor. No, don't push more, please. Try to make a brace that can bring the patient to this. Listen, physiotherapist, a brace is a stupid tool. A static tool cannot move, cannot do what you would like the brace to do. So everybody in the team needs to know the limitations of the other, and everybody in the team have to take the responsibility of assume that when patients go well because the team, and when patients goes bad because the team is not able to offer something else. Some cases are really very progressive, and we can not manage them non-operatively. And at the end of the day, they can need an operation, and then you need a very good surgeon for that. You understand? So this is more or less the message that I wanted to give. The interdisciplinary team approach is not the same like multidisciplinary, where people choose what they want. It has to be really oriented to the patient, but you need something with the experience really to give the best advice, okay? Research is open now. We have much more questions than answers. And this is why we need to work all together in once we get the answers to all these questions that we have, then how we are going to use it for the benefit of the patient. To finish, yesterday I was listening in Valencia the presentation from Dr. Francisco Sanchez Perez-Grueso, one of the most important surgeons in the world that during the last years, he's now emeritus professor at the Hospital La Paz in Madrid, and he was presenting his personal perspective looking at the patients he operated 30 years ago with a single procedure, the Cottrell-Dubosset instrumentation, and he was presenting the reality. Some patients, most of the patients in this group that he presented were doing fine and were satisfied and happy for what they made, but some were not. And he was using some sentences from the patients telling, for example, I remember a girl telling, I was forced by my parents decided for me the operation, I didn't want, and now look at how I am. My life is destroyed, or something like that, okay? Others telling, the operation was for me a miracle, it changed my life. So at the end of the day, you will discover that people living adult life with a scoliosis is about their own perception, how they feel. And you will find people who is accepting the situation, they are satisfied, they are doing well, they are doing a normal, more or less normal life. And no matter what they did, operation or non-operation or nothing, at the end of the day, they are satisfied with what they did. You have said, are you happy because your operation? Yes, I am. I'm doing fine. You ask in the other side, are you happy not getting an operation? Yes, I am. Look at me, I am doing a normal, good life. And then you have the other side, people that for any reason is not doing well. And we don't know exactly the reason. And it's not the two poles. It's nothing related with the scoliosis that you are not doing fine. Or it's all related to the scoliosis that you are not doing fine. It's a mix of things, and unfortunately we don't know which is the proportion that the scoliosis is guilty for that and which is the proportion for other issues to be guilty for that. Okay, so this is something we have to find, to help these people that is not doing fine. And is not doing fine, then if you ask them, are you happy from your operation? No, I wouldn't do. Never. Okay, look at me. If you ask them when they were not operated, no, I hate, I needed an operation then, you know, now I need the operation if I were. So this is all the time what happened with patients living their lives as adults with the scoliosis. And this is what we really need to learn, and how we can serve them and how we can help them. Okay, so this is my reflection about that. Gary, I was a little bit longer than you asked me, but if you want, we can make the closing. Thank you.
¿Tenéis alguna pregunta? No? I would like, thank you very much, Dr. Rigo, for this moment and all the knowledge you have. I would like to ask you about your experience. During this way, how many times did you change your criteria to go forward with the patients and saying, oh my God, maybe yesterday I didn't do the things as I would like to do it, and I need to revise and to assess again to help better the patient?
It's well, this is a question related more with life than just with the profession. I think that probably somebody telling I don't regret about anything, reaching the time I am, not very far from my retirement, probably is not open or thinking about things. I regret a lot of things that I made, especially producing iatrogeny. This has been my main lesson of humility here, is that all these tools that we use, and I don't say only the brace. The brace is the tool, the most important tool you have to prevent the progression of scoliosis together with the physiotherapy. The point of the brace is that you have an object to be analyzed in the time. It's not so easy to analyze and to self-criticize what you do with the physiotherapy, okay? Because you don't leave an object to be judged by everybody, right? A brace, yes, is an object that is there on the patient and everybody can say about the brace, okay? So we have to be very respectful with the orthotist. Probably the orthotist is the weakest part of this interdisciplinary team, because everybody is able to say the orthotist, you made a bad brace, okay? The orthotist, when things are doing fine, the team is doing fine. When things are not doing well, now most of the time is because the brace was not good. So the orthotist is always the weakest part of this team, and we have to support them, to educate them, and to bring them into the team and understand, okay, we know what you can do and we know the limitations of that, okay? So this is from my side. What I regret is many times try to do things with the best intentions, with the knowledge I had at that time and with the evidence we had at that time. Doctors, physiotherapists, orthotists, you are taking risks sometimes, most of the time, and the life show you at the end what not to do more, what not to do again. So nowadays I am very aware about what I would not doing again, okay? However, I don't know what I will be doing, and if what this I do, it will be good or not. That's life, huh?
It's true. It's
Not
true.
only about medicine.
Yeah, this is the life. Yeah, it's true. We have here in the chat a new question. Borislav Tongov from Bulgaria is asking, from our experience and following the SOSOR guideline, we began to ask ourselves, the question is, if we could put a brace at 16, 20 degrees cup angle at research 0, with visible rotation only for 9th part, together with PSSE, to prevent progression and to prevent, if it's possible, the full-time bracing in the future.
Question is
If we can put
about the angle?
16 and 20 degrees.
16 degrees?
Yeah, 16 and 20 degrees, research 0. The question is, if we can put a brace in this case to prevent in the future with a visible rotation in the patient, only for 9th part, if it's possible to prevent in the future the full-time bracing using now 9th part brace combining with PSSE, if we have a patient with 16 to 20 degrees with research 0.
What to say? You can do, but the problem of this is that if you do that, you have no evidence at this moment to say that doing that you will prevent what you want to prevent, first point. And second, the risk of over-treatment and iatrogeny is relatively high, because especially in early onset scoliosis or in early puberty, when you have a very mild scoliosis, even with a clear clinical picture, the curve pattern is not yet well defined, at least not defined in a way that we know exactly what to do with the brace or what to do with the physiotherapy, meaning that you can change at the end the pattern. For example, if you have a scoliosis with a big potential from progression, from a growing torsion, those of these bad responders, and you treat them very early with a hypercorrective brace nighttime with the idea of preventing progression, maybe the only thing you do is to bring the torsional effect higher and at the end developing a very, very bad iatrogenic proximal curvature, which is then a big problem, okay? So nowadays, at this moment, in cases like this, my recommendation used to be very conservative, okay? And conservative here means observation. But again, this is one of these cases in the gray zone where you could do, because looking at the SRS guidelines, bracing would be a low from 15 degrees, so you wouldn't be against the guidelines, okay? You could do it, but then you have to be aware about this risk. And this is the lesson I learned in my life. Doing this, I saw what happened most of the times, and I am much more afraid of what happened than of the scoliosis at the end going into progression. At least you know now what you have to do, and you know which is the expectation for this treatment, okay?
Thank you very much again for your time and for your answer. Thank you.